have a little change in the program. Dr. Amsterdam, who is the next speaker, was unable to make it. So what we're going to have is I'm going to ask Dr. Kopecki, Dr. Fowler, and Dr. Mendy, and if Dr. Block's still here, to come up, and we'll do a little Q&A panel with the speakers.
I think this will be a great opportunity for all of you to ask any of your questions, not necessarily on, it can be on anything in cardiology. People want to ask about atrial fibrillation, or any of the other topics on prevention. Our speakers have been kind enough to have a panel. So we'll do this for the next section and then have our break. Okay, let me lead off, I guess. Dr. Fowler, I have called you in the past on patients with a peripartum cardiomyopathy. I told you there are no beds.
That's the usual line.
What about patients who are with peripartum cardiomyopathy who are now breastfeeding? I currently have a patient who with an ejection fraction of 20 to 25%. My first question is, would you recommend a life vest? And the second question is drugs that she wishes to breastfeed. So,
well, two very, very questions I think have no right answers. The guidelines, of course, the use of beta blockers in patients with pregnancy suggest that atenolol has a warning attached to it, metoprolol doesn't have. And that's partly because there is data with atenolol because nobody in their right mind would use metoprolol. So atenolol is a drug that is lipophobic. Atenolol and metoprolol, the effective beta blockers in heart failure, are lipophilic. So if you look in the amount that crosses the placenta and the amount that gets into breast milk, it's one of the few instances where perhaps a drug like atenolol is safe and acceptable, especially at that stage of the pregnancy. A more difficult question is if you had a patient with previous peripartum cardiomyopathy who's become pregnant again, whose LV is not completely normal. But again, I'm giving those patients atenolol. They, of course, can't have an ACE inhibitor or ARB. My understanding is I try to leave it when they're breastfeeding. My understanding from my colleagues in high-risk obstetrics that by the time the babies come out and they haven't got finger webs and they've had apoptosis, that actually the ACE inhibitor or the ARB, so contraindicated during that first trimester, are probably acceptable. I don't think we know enough about spironolactone. So I think it's a very difficult position to be in. I think there is the difficult thing about peripartum cardiomyopathy. It's probably more than one disease. One group's going to get better completely, perhaps had a preeclampsia, they had a stressful pregnancy. Another group perhaps has a pre-existing condition, maybe they're amphetamine addicts, and maybe they've got other reasons or familial to be cardiomyopathic, and others are the true peripartum cardiomyopathy in which I think some get dramatically better quite quickly and some don't. I think that the patients we've often felt have been doing well and they've suddenly gone downhill, we've scrabbled to transplant them. They're clearly at risk for arrhythmic sudden death. I can't think of a more uncomfortable circumstance into which to try and wear a life vest, but I think for most patients with a young family, I think that would probably be acceptable, particularly with the ejection fraction where you describe your patient, than while they wait to declare themselves about a permanent defibrillator.
So 2 months post delivery, she happened to be admitted and the hospital repeated her echocardiogram. Ejection fraction remained 20 to 25%. And we tried to get the insurance company to approve a life vest, and they absolutely refused.
I find that surprising. Most insurance companies, and I think most state insurances, Medicare and Medicare, have been very cognizant of the fact that you've got a risk that you can cover to a large extent effectively life vest. It's difficult, though, because, of course, in the trials, which is why I think they turn around and point them back at you, in the trials, there was no survival benefit until you had waited until effective therapy had had a chance to be applied. I think you're going to be restricting how effective your therapy could be, and I think that's exactly the kind of person who should have been implanted with a life vest. And all I can do is I think you petition that insurance company, and you've got yourself now in a very difficult position where you've recommended something and the insurance company said no. Is she all right?
She's doing okay.
Good. I thought you could have some terrible third phase to this story. So.
No, she's doing okay. I mean,
That is surprising. I'm afraid that by that stage, I think the ones who are going to get better often have already started to get better. So I think you've got a patient who, unfortunately, for whatever reason, is going to have a long-term issue with this.
Okay, questions? Yes, Dr. Sharma. Dr. Sharma?
I'll repeat the question. So the question was an appropriate question, and I've actually tried to avoid ever giving this lecture on treatment of patients with preserved systolic function who make up, particularly in women, half the hospitalizations for heart failure. So we talked about those million plus hospitalizations, half women, half men. But in reality, the women who get admitted with heart failure are often the more elderly patients who have heart failure preserved or nearly normal ejection fraction. And the questioner is entirely right. We have made no progress. Perhaps part of the reason we've made no progress is because we haven't failed to recognize that it is multiple diseases. And maybe that the heart is not the primary problem in many patients with heart failure preserved ejection fraction. Maybe it's disease of the periphery that moves the heart. Maybe the diastolic dysfunction per se within the heart is a small component of a patient with abnormal vasculature, abnormal renal function, very high comorbidity rate. So every trial that's been looked at specifically using the current therapies we have been neutral. And we end up giving the presentation saying, well, try and manage fluid balance. They're rather brittle. Treat blood pressure, manage ischemia, manage heart rate, meaning fast or slow, treat AFib. And at the end of the day, the drug that came closest to showing benefit, and if you took out, I think one should these days, if you take out the Russians and I think the Ukrainians, they must have been together on this, and you take the Raoul's trial and you looked at diastolic dysfunction in patients who were from Canada and the Americas, then there was a benefit from spironolactone, including meeting its primary endpoint. I try to use spironolactone if I can, often renal dysfunction, often patient population, you've got to make certain you can monitor their potassium. But I don't think, apart from, I couldn't agree more, we have not made progress in a complex disease, and we know it's not all the same disease. We know a patient with radiation-induced heart disease, a patient with burnt-out hypertension, a patient with amyloid, a patient with senile amyloid. They're not all the same patients. Hypertrophic cardiomyopathy.
Can I ask Dr.
Yes.
Can I ask a question, Dr. Fowler, about
What about physical activity? Not for the amyloid, of course, or the radiation-induced, but physical activity for the obese, the hypertensive, et cetera.
I tried to bring it up in my talk. It took 2 seconds, and I said, now CMS are paying for. The Europeans don't run a heart failure program. It's a slightly different system there, as you know. It costs them still a lot of money to look after patients with heart failure, but they're not for-profit centers. They do use a huge amount of ads. Germans use the most ads of anybody. But every heart failure program in Europe, almost by requirement, by government sort of edict almost, has a rehab program, a physical rehab program, a physical exercise, and it's the supervised diet and exercise. It's not a physician with an English accent say you've got to walk more and you've got to do more. It's supervised diet and exercise that has been found to be so effective in randomized trials in Europe of improving quality of life specifically, and then keeping them out of hospital, and then some trials, I'm not absolutely convinced, as I said so earlier, I'm not absolutely convinced of the survival benefit, but in terms of quality of life and what they can do, supervised exercise program has been very effective in systolic and diastolic heart failure.
Do you think any of these future trials, of which there have been a whole series of drugs for diastolic failure, is it now unethical not to have the control group be on physical activity?
Oh, I think that's true, and one hopes that any trial that's being looked at for a new medicine, particularly in diastolic heart failure, where none have been actually met their primary endpoint of being successful, yes, do what has worked. And all those patients should be on optimal management, which should include supervised diet and exercise. I think Tinkerbell's calling.
All right, questions. Dr. Kopecky.
It is mine. God.
And here in California,
I didn't run late.
Here in California, our patients like to use a lot of vitamins. Now, every conceivable study on every conceivable vitamin that I know of does nothing to reduce or improve your health. What do you say?
Well, there's a great ad on TV, and I don't want to pick on any brand, but they've got this ad on TV. They say when doctors wanted to study vitamins, they chose Centrum as the vitamin to study in a randomized trial. And that's exactly right. The ad go on to say how great Centrum is. They never say that the study didn't show any benefit. And so the American way is to take something that's in a fruit or a vegetable, desiccate it, put it in a pill, and sell it back to us for a whole lot more money. There is no evidence that any of those things help. I actually have a patient who's the chief scientific officer of one of the major intravenous feeding labs in the world that sells these intravenous fluids that people that don't have guts, they've had their small bowel taken out for whatever reason, they feed them. And I've asked him one day as a patient, I said, what is it about fruits and vegetables, is in the skin of them, that makes us live so much longer? He says, we can identify all these things in fruits and vegetables. We know the micronutrients, but we don't know which ones have to be there together, help us live longer. And so if you think about it, a fruit is where, by definition, where the plant has its seed. Did the fruit want you to eat it and die? Or did it want you to eat it and live and spread its seed? You know, teleologically, it wants you to eat it, live, and spread its seed. So there's good things in fruits and vegetables. Now, having said all that, what has been shown to be helpful? I think clearly that that fish oil has been shown to be helpful because it lengthens telomeres, which lengthens the cell life. It helps in lacrimation, studying it for Alzheimer's. It helps in cell life. It reduces wrinkles in the dermatologist. When I told my wife that, I now buy twice as much fish oil in the morning because she wants to take it. But no other nutrient really has been shown to be helpful, and some have been shown to be harmful. And I actually saw a patient 2 days ago, or Friday, in the emergency room, and she was taking one of these supplements, and I said, you know, you should really take that. She was 29. Said you should take those supplements and the money and instead buy, you know, your kids put in their college fund. She said, well, I get them for free, I distribute them. So it's a multi-billion dollar industry, as you know.
Okay, that answered that. Yes.
Yeah. My question is that I have a patient, moderately obese, sent for the sleep study, and during the study it was found patient may have a paroxysmal atrial fibrillation. Patient was evaluated by the cardiologist, was diagnosed with the paroxysmal atrial fibrillation, started on the antiarrhythmic medication, and talked about the anticoagulation. Then it was told to the patient that it's between you and your primary care physician to decide about the anticoagulation. So now the ball is in my court, and I don't know what to do.
So if I understand you correctly, the cardiologist said it's up to you and your primary care provider. So, you know, there was a study on even high-risk patients, and I'll ask any of the speakers to comment. The average, if you have patients that are elderly, and your definition of elderly, again, if somebody is 80 and above, you have to fall about 90 times before you can say that patient is high risk for anticoagulation. So 1 or 2 falls does not disqualify the patient for anticoagulation. So we clearly underestimate, and 50 to 60,000 strokes we can prevent annually if we anticoagulate our patients with atrial fibrillation. So clearly that decision, should be on the cardiologist. So in collaboration with the primary care provider, but any comments?
Only that I agree with you entirely, and I think that often the anticoagulation has to be sold to the patient. I say the trouble is that when you get your stroke, you might live. And then I look at their spouse. And, and the terror and the discussion on the way home usually has that patient anticoagulated. I think it's remarkable how often we look for an excuse not to do it. It was so much more difficult at 5 o'clock at night, and it was an ebb tide, you wanted to go windsurf that evening, and the patient was there with atrial fibrillation, and you had to initiate warfarin therapy, find somebody to run the INRs. It's so much quicker now and easier with the novel agents to point out the benefits. And I think there are going to be antidotes. In fact, there are antidotes being developed. I think we've run out of excuses not to prevent the strokes that we clearly can prevent. So I couldn't agree with what you said more.
As far as if you have a patient that has atrial fibrillation, and a normal ejection fraction, and the patient's doing well, what heart rate is acceptable for you?
110, less than 110 at rest. And if you have a patient that I usually take them on the exam table to have them do 10 sit-ups, if they go from, say, 100 up to 140 with 10 sit-ups, then you know when they're active and their parasympathetics turn off, they really get too fast that early. And so we'll maybe get them a little more medication to slow their rate some.
That's a good thought. I've never done
I
that.
tend to run mine a little bit slower than that, although I'm very aware of the data that suggests there's a distribution of poor outcomes at the low and fast heart rates in sinus rhythm, which appears not to apply to atrial fibrillation. Nevertheless, I have this fear of the patients you see not infrequently who do develop left ventricular impairment of systolic function due to a persistent rapid response to their AFib. So I'm a bit nervous if they're in your office at 110 for part of the reasons you say. Do they take their other medications reliably? And what are their heart rates much of the day? So 110 seems a bit quick to me, but I know that you're supported by the data.
Yes.
Factory supplements, no. Consensus of 5, let's say. A couple years ago in September, the New England Journal reviewed calcium supplements in the diet and reported 13 studies showing an increased heart attack risk with calcium supplements. And a year and a half ago, 20,000 women did not benefit from fracture risk. I presume they were osteoporotic patients were excluded by taking calcium supplement, which only minimally elevates bone mineral density anyway, 10-12%. Do you have an opinion about whether we should discourage calcium supplement use in non-osteoporotic women? And what source would you use for calcium?
Yeah, that's a huge question about calcium. And it's gotten to be quite controversial. And it just so happens that the National Osteoporosis Foundation and the American Society for Preventive Cardiology is writing a white paper on this, and I'm actually the chair of the writing committee. So what happened about 5-6 years ago, Boland and his associates from, from New Zealand, Australia, picked out certain subgroups of randomized trials and actually picked out the group, and not all the patients, but just some of them, and said if you look at these groups, they had higher heart attack rates when they took calcium supplements. And then and it got a lot of controversy. So if you go back and put all the patients together from the trials, there is no increased risk. Then if you look at Framingham's data, that's where Framingham has told us all of our heart risk factors, everything. They actually looked at this and found no correlation between taking calcium supplements and having heart attacks and strokes and such like that. So the answer is there is no evidence. The FDA has looked at this. They have said there is no evidence. But still, it gets out there and everybody thinks that calcium is actually bad for you. It increases your heart attack risk and increases your coronary calcium, which is absolutely false. It is completely a separate calcium pool. So it does not increase cardiovascular risk, and we have to keep writing papers and talking about it and saying if the woman needs it, or the man for that matter, on the advice of his or her caregiver or doctor or nurse practitioner, then they ought to make that decision to take it. Don't stop it or don't not take it just because you're worried about heart risk.
Yeah, right.
Well, I think, when the calcium story as supplementation became popular, I guess it's about 30 years ago, being a nephrologist, we saw a very nice increase of urinary calcium stones. And it usually was in the males. It wasn't in the females. And, the wife started taking it at age 50, and the guy said, well, it's good for her, it's good for me. So I think that if you're borderline with urinary calcium excretion, which you really wouldn't know, and as a male, particular, start to take 1,000, 1,500 milligrams of calcium, and you may actually, potentially have a kidney. So I would say that males, which you also have osteoporosis, you treat, I think you probably at one point, if you go beyond the 1,000 milligram, I would do a 24-hour urine calcium excretion. I think to 500, 2,000 milligrams, you're fine. But if you go to higher dose because you think you need it, it's worthwhile to just make sure you don't get into the calcium, stone forming range. So.
Questions? All right, let me ask a question. The entire world has gone away from, probably Dr. Fowler, but anybody's. The entire world has gone away from using aspirin in atrial fibrillation who have a low CHADS-2 VASC score. The score is 0 or 1. they're saying aspirin is not beneficial and harmful. U.S. except for the United States guidelines. The rest of the world, Asia, Europe, NICE guidelines, everyone says no aspirin. Why do we still have it in our guidelines?
I think we're often slow to drop something that's not been beneficial. Sometimes that's perhaps been quite good. The NICE guidelines are very dependent upon evidence-based medicine, and they worship heavily the altar of evidence-based medicine. If you can't find benefit, they're going to claim there's harm. There's very, very few effective primary trials done with aspirin, and that's part of the reason they've been dropped. You could argue the huge increase in bacterial endocarditis seen in Europe because of the guidelines suggesting there was no benefit for prophylactic antibiotics and mitral valve prolapse. They're probably going to get changed. They track their data. So I personally don't think aspirin's useful, but at the same time, it's quite nice if you're not going to anticoagulate somebody because of a low CHA2DS2-VASc score to look for that excuse as to why they might need aspirin.
Okay.
I have trouble with it, but I do believe the data that suggests it's not beneficial is probably correct. It's just we never established it. It's a different type of lesion, and maybe you don't affect large thrombus formation the same way as you do platelet activation within vasculature.
In fact, I agree completely. The only trials that really looked at aspirin alone versus warfarin were the SPAF trials, the stroke prevention and atrial fibrillation, which were funded by the NIH. And they actually showed that warfarin would reduce stroke 80%, and aspirin reduced stroke 20%. And that's where this kind of myth got started. Oh, it helps, it works. But it's not quite enough. And so the idea that give somebody aspirin instead of warfarin is really not the answer. Yeah.
Question?
Recently, retrospective analysis of study from UK about LDL and reduction in the lipids was published, nursing home patients. And essentially, even though they replaced all the butter and animal fat with vegetable oil, they reduced the LDL, but no benefit on mortality or morbidity. And so linoleic acid is coming out to be a very bad thing. Any comments on that? Dr. Kopecky mentioned that LDL is not considered one of the risk factors that has been actually studied. And your comments on this retrospective analysis, side effects of linoleic acid, should we go back to eating butter instead of vegetable oil?
Some of us never stopped. Some of us ate all the fat we could and tried to avoid the obesity epidemic in the United States when misguided politicians told us not to eat fat with no data, and so we ate sugar instead. And of course, all the margarines and the trans fatty acids. I wonder how many nurses were sacrificed in the nurses study to prove that they should have been eating butter all the time.
And that really is true. I mean, the American Heart, pushed everybody away from from fat, said eat low fat, so now they eat a high carb, which is just as bad. And so the really only diet that's really been shown repeatedly in multiple studies. In fact, the last 5 studies, the Mediterranean diet has beaten the American Heart low-fat diet in every study. In the last study, the Predimed, which was in New England Journal 3 years ago, January, they actually stopped the study early because they said it's unethical to continue this study and have one group eat Mediterranean, the other group eat American Heart low-fat. And so the Mediterranean's very high in fruits and vegetables, very low in animal fats, very high in things like nuts. Olive oil is extremely high. So it's not a weight loss diet. It's not a lower your cholesterol diet. In fact, it doesn't change cholesterol at all, but it does help you live longer, feel better, have less strokes, heart attacks, less metabolic syndrome, less diabetes, less Alzheimer's, and less arthritis. That's all been shown in randomized trials.
Yeah.
The question is, what about plant-based low-fat diets, like no-fat diet, like Esselstyn's? Yeah, no oil. A couple of things about it. One is, I don't know if anybody here has had patients go on that. You have to watch those patients when they start to eat when they eat no fat. they eat a lot of carbs, and you have to watch them to make sure they don't develop high sugars, because some will if they don't have very good insulin. The second thing is that diet is based on 30 patients and one angiogram that Esselstyn has shown all over the world. It has never been a randomized trial. I have had patients go on it and they can't stay on it. I've tried it. I cannot stay on it. We need something that someone can eat, stay with, and is proven to be beneficial. If it works for you, I'm not going to try to talk you out of it, but there's just no data that shows it's beneficial, and you just can't stick with it.
Question back here.
Can you comment on the maze and the mini maze, all these procedures?
Comment on the maze and mini maze for AFib.
So there are surgical groups that are advertising in the newspaper and making rounds around the state, promoting the maze and surgical maze and thoracoscopic maze procedures for patients with atrial fibrillation. So the question, I guess, is which are the best candidates for those procedures?
My feeling is that there is a non-surgical approach to atrial fibrillation which is effective in selective patient, which is the transeptal ablation, classical afibrillation. And in selective patients, that could be very effective. And I think the mini maze and the maze procedure should be reserved for patients who are having surgery anyway. So if you've got some paroxysmal atrial fibrillation or a large left atrium and doing mitral valve surgery, that's the patient I think should get a surgical maze. I see no reason nowadays for a primary surgical maze when you've got effective transcatheter techniques to achieve the same end.
And I agree. I think it's less invasive. I don't think patients need to go unless you have really a complicated patient, recurrent heart failure and so forth. The other question is, remember, if some of these patients, even percutaneous catheter ablation, I do not recommend discontinuing their anticoagulation. These patients, if you have atrial fib, in general, you have atrial fib for life. If you discontinue the anticoagulation and the patient has recurrent AFib, they're at risk of a thromboembolic event.
I couldn't agree more. There's more and more data suggests that perhaps we were simplistic. If you look from recordings for people who got devices, defibrillators, and you look at the amount of mode switching in AFib they had proximal to when they had their stroke. Some had the classical go into AFib for hours and get the stroke, but some it isn't related to it at all. It seems to the substrate in some patients as much as the AFib per se. So patients who are getting afibrillation procedures in order to get off anticoagulation is a simplistic complex concept, which certainly in the patients with a high chance vasculars probably should never stop. There might be the occasional patient who has a low score, normal left atrial size that you can stop perhaps after a year or two, but I think every time you stop anticoagulation in a patient who's had prior AFib, you're leaving them vulnerable, particularly if they're not aware of the redevelopment of the arrhythmia.
Something which is way underdiagnosed is that the AFib also can do renal emboli. So you have somebody who's developed flank pain, and then you get a touch of hematuria, and the diagnosis is kidney stone. So there's a very easy way to make a diagnosis. There's no more LDH in any organ than the kidney. So all you do is if you have flank pain and you're in AFib, and you have get an LDH, you'll do 2,000, 3,000 because you will have a renal infarct. Just the total. I mean, the LDH5 is the highest. Yeah, but you don't even have to fractionate it. I mean, the total LDH is just way out of proportion. And that's such a nice, easy, and it's actually much more common and recognized. Yeah.
Wow, that's great. Let's talk about the labile hypertensive patients. It's very easy to say, get a 24-hour ambulatory monitor to see if they truly labile. But there are patients that come in with blood pressures that spike to 180, 200, and then down to 90 millimeters of mercury. How do you deal with that labile patient?
Okay, I think there are usually the ones you talk about are probably the ones in the 70s and 80s and 90s who do that. I haven't seen anybody in the 30s and 40s who goes from 90 to 90. I mean, but I think that I tried to address a little bit from the one editorial with Dr. Weber from the last couple of weeks ago. So basically, we actually need to look at the labile hypertensives a little bit more is that what do you have with it? Do you have LVH? Okay. Do you have, what your fundus look like? And so if you have any other abnormalities, I think you need to be much more aggressive in treatment. And I think if somebody, look, if your systolic is 100 for, let's say, 2/3 of the day, and I'll start out with 10 milligrams of lisinopril, I'm not going to drop your pressure. Okay, so basically, and it's the same as for the person who gets late bile alcohol spikes with exercise. So I think you gently increase your ACE inhibitor at bedtime is the ideal time, so that you avoid this daytime low pressure, and you actually will find that many of them you get around the lability. I would not use a diuretic first. You volume deplete them, you make them all worse. I would not use a vasodilating drug like calcium channel blocker. I probably just go with an ACE or A or B as the drug to reduce that lability. And again, look at is it just the patient's lability, or is it just? And also very often what I look at, and you'll find that too, is the pulse rate changes. If somebody's pulse goes from 70 to 110 because they're anxious or and the pressure goes up, well, then you should address the pulse rate and not the blood pressure. So then a touch of a low-grade beta blocker should take care of that. So look at the pulse rate if it parallels the lability, and if it doesn't, I think then my choice would be a low-grade ACE inhibitor. I don't know whether anybody has any thoughts on this.
No, but I do worry that I've heard a rumor that the new CMS, one of our new core measures, is going to be office blood pressures with targets down in the 120s. And I can tell you, even my heart failure patients, maybe because of anxiety, look at their mean heart rates, but they're often above that. They're already taking maximal therapy with a complaint of postural hypertension. And do I just lie on my charts? I think that's what I'll do. I'll claim to recheck all the blood pressure. But I can retire soon. Got a birthday next week. How are you going to deal with this ridiculous new core measure, which is a blood pressure that's going to fracture a lot of hips, cause a lot of watershed strokes, and frankly chaos amongst the elderly?
I think that hopefully within the next 2 months, the ASH, the ACC, and the American Heart Association will come up with guidelines. And for the first time, because of the SPRINT trial, we have to say, is this an observed blood pressure reading in the office or unobserved? Because the SPRINT, I alluded to this morning, all the SPRINT data, they were unobserved. They were 15 minutes in there alone, and there are already data from the literature. If you actually step in, the systolic is 10 millimeters higher.
But I've heard that CMS are going for the SPRINT numbers.
Yes.
And it's going to be a core measure. And there's nobody in the United States who's got 15 minutes to leave a patient alone in the room and creep up on them and get their blood pressure. We're going to make up the data, I assume.
But I think the editorials, you will see a lot of discussion in the hypertensive literature saying that the SPRINT numbers of 120 need to be increased by at least 10. Because at least 10 millimeters, and some talk about 50 millimeters in the discussions because of the observed versus the unobserved blood pressure.
I was just going to point out that at Mayo in Rochester a few years ago, we elected to go to BP True, which is exactly that. Every patient now that comes in, 800, 900,000 a year, get put in a room quietly with the BP True automatic device, get 6 blood pressures, average it out, and that's our numbers. That's just what we're doing, But.
Well, maybe Mayo has the extra room.
Would you be able to address the patient with recurrent TIAs or CVAs who is not in atrial fibrillation, and how you manage that if they've failed one blood thinner or another? Is there an optimal combination, or what do you do?
The question is patients with recurrent TIAs that do not have atrial fibrillation. Well, one of the rare things you've got to look at is to make sure the patient doesn't have a PFO. The other thing is you've got to make sure that the patient truly doesn't have atrial fibrillation. If the patient has recurrent TIAs, that patient, beside an event recorder, probably needs a loop recorder, an implantable loop recorder that takes really 30 seconds to a minute to implant and can be left in place for up to 3 years, has a battery life of 3 years, to see if indeed the patient truly doesn't have atrial fibrillation. And if the patient doesn't have a cardiomyopathy with an apical thrombus, There's not much else I can think of. I would put the patient definitely on clopidogrel. I wouldn't commit anticoagulation with warfarin or one of the novel anticoagulants if they truly do not have atrial fib. Any thoughts?
Yeah, the only I would agree completely with that. The other thing is look at their TIAs, and if they say that, gee, one TIA was my right hand, the next week I had my left leg, and those are embolic like TIAs. But if they say every time it's the same thing, it's my left arm, my left arm, my left arm, that's probably more of a local event, because if you have an emboli, it goes all over the place. But if it's a local event, then it's the same serotypical symptoms every time, and then you need to look for imaging and make sure there's nothing locally that's causing it.
And I have been fooled before. I had a patient very similar to that. Turned out that the patient had bacterial endocarditis. So, and embolized from the endocarditis.
Do we know this patient did not have carotid disease?
Well, I'm assuming that you ruled out all these things.
Okay. Questions? Here's the opportunity, guys. Yes, please.
Yeah, pharmacogenetics. Where are the trends in a lot of these cardiac cholesterol medications, statin non-responders, for example?
Talking about PCSK9 or something different?
Just more of how much that study is translating into cardiac care.
It is interesting, the pharmacogenomics. We did a study at Mayo of 200 consecutive statin-intolerant patients and looked at their pharmacogenetics. And the only thing we found, we didn't find anything that increased the risk of intolerance. What we found was one disease that decreases the risk for intolerance. It was actually Gilbert's, this elevated bilirubin that we have, that they actually had less statin intolerance. They have a better liver that can metabolize it. There's nothing that really pans out in statin intolerance, probably because it's such a multifactorial disease. There's so many things that can cause it. Probably the big thing I can think of in genetics is the clopidogrel, the prodrugs that need to be converted to an active drug like clopidogrel. Some of us have that gene, some don't, and actually there are a lot of ongoing studies to see if giving the gene test and then giving them prasugrel or one of the other drugs rather than clopidogrel is actually beneficial.
But having said that, the field seems disappointed at the cost and complexity. And the clopidogrel trial, which should have been positive because it was more than any other should have regarded pharmacogenetics, was actually a negative study. So I personally think the idea you're going to choose which beta blocker you give, buccinol or not, based upon a pharmacogenetic test, I just think it's very impractical and difficult to do unless you've got some huge difference. And even there, it hasn't borne out as much as we thought it would.
Yeah, in patients say, well, can you genetically test me, doctor? And I'll say that genetics, like for the 50 different genetic markers that have been shown to increase your risk of heart disease, if you have them positive, they'll increase your risk by 1.3, 1.4. If you don't eat 5 fruits and vegetables a day, you don't get vigorous activity every couple of days. If you smoke, if your BMI is over 30, that increases your risk not 1.3, but 4.0. So you can't change your genes, but you can modify the effect of them much more than the gene. Your lifestyle is much more important than your genes. So the current kind of glib answer is that your zip code is much more important than your genetic code for your health.
What about the use of Coumadin or warfarin versus the NOACs in patients who are obese? I know there's been new literature out there saying that NOACs or the novel oral anticoagulant shouldn't be used in very obese patients. What is your thoughts on that?
Anybody? I have no thoughts on it. I don't know. Personally, I think the only reason, and let's clarify this as well, because the package insert on these novel anticoagulants say non-valvular atrial fibrillation. The only patients that do not qualify for the novel anticoagulations perhaps is rheumatic mitral stenosis. Patients with aortic stenosis, you can prescribe the novel anticoagulants, even patients with moderate to significant mitral regurgitation. And the only reason that's in the package insert is because those patients were not included in the trial in preparation for surgery for those patients. So and I'll be happy to be corrected, but in my book, the only reason not to prescribe a novel anticoagulant is somebody with a prosthetic valve, mechanical valve, and cost. Any?
No, I'm pleased you added the mechanical valve.
Mechanical.
Because I think that is an absolute contraindication, and sometimes I have to look back and find out, was that a mitral valve repair, was it a bioprosthetic valve, or was it a mechanical valve? I can't remember. And that's the one error I think you could make, apart from what you said, rheumatic mitral stenosis. But I must admit, I've got some patients who are completely non-compliant with warfarin, and one of them has a functional mitral stenosis, severe mitral stenosis, valve-in-valve action, failed bioprosthesis, and then a TAVR put through his mitral, huge clot with his left atrium, completely non-compliant. In fact, I think he lives near here. And he is doing pretty well with he actually does, with his novel oral anticoagulant. But again, they're not mechanical valves in the sense there's nothing. Well, yeah, probably Eliquis is right.
Eliquis.
Expand.
Yeah. I was going to say the data just isn't really there for the obesity, but for the apixaban, if you have two of the three, BMI, or rather weight less than 60, age over 80, or creatinine over 1.5, you should go to a lower dose. So we know that those folks need less dose. Is it clear that the obese patients need more of a dose? That's just not, I haven't seen that data. It's just not.
There is data now to support using apixaban in patients with chronic kidney disease and on dialysis. And still the same standard dose, except for the criteria. Two of the three criteria: weight less than 130, creatinine more than 1.5, and greater than 80. If they meet two of the three, then we lower the dose of all of and they're not really called novel anticoagulants anymore. They're calling them non-oral vitamin K antagonists because they're no longer novel.
I understood also there is some controversy still as to whether there is benefit in end-stage renal disease patients on dialysis, at least from retrospective analysis of the use of coumadin warfarin. So I think there's a bit of a debate, and there's some trials being done now to already establish if you're on hemodialysis with end-stage renal disease with a very, very high hemorrhagic stroke risk, whether you should be anticoagulated or not. I found at Stanford we got one group of nephrologists to allow us to, and one group who are dead set against it.
Yep. I think we're the same. I think it's unresolved. So.
Yes.
We often have to adjust doses for patients with cardiovascular drugs based on renal function. It's hard to know renal function. Little ladies will weigh 100 pounds, and when we use the creatinine-based GFR, is there a C-statin test I can order that actually tells me function and not just a normal range? Or, it gives me a kidney function instead of just...
Okay. Well, I think if you look at the data from San Francisco, actually, if your eGFR is between 45 and 60, okay, in an individual which is 100 pounds or has no muscle, and you question the accuracy, the International Kidney Society in the U.S. Kidney Renal Foundation, etc., suggests for you and that person to do a cystatin C test, and it's a blood test, and the cystatin C is put in the same formula. It costs $3 or $4, like you would calculate the creatinine. So you use the cystatin because it's not dependent on weight, it's not dependent on your age, it's not dependent on your protein intake. Having said that, if your eGFR is 65, and you say, I'll do them both. I do the cystatin C and the creatinine, they're within 3 to 4% of each other. But let me give you the numbers. If you're between 45 and 60 with creatinine, and you are, there's something suspicious what you just mentioned, and you repeat in those people, 42% are above 60. And here comes the really important thing. If you happen to have type 2 diabetes, something is different with your muscle. 66% of all type 2 diabetics between 45 and 60 have an eGFR over 60. So the VA actually in San Francisco is actually looking almost in some hospitals now starting to do an automatic cystatin C eGFR if you're between 45 and 60. And if you go to places like MD Anderson for oncology, and you're between 45 and 60, you have both because of the dosing. So we're looking at, but if you're less than 45, both tests again are very similar. Don't ask me why, but that's where we are in nephrology. So between 45 and 60, it may be worthwhile to do it. Right, but you only have to do it once. See, if your eGFR is 62 as a statin and there was 50 with creatinine, you don't have to do it each time. That's right. You got them spaced. You got them diagnosed. That's what we do. That's what we do. Correct.
All right, I'll ask the last question, I suppose, Dr. Kopecky. Why can't the lipidologist and cardiologist get together when it comes to fractionated lipoprotein profiling with the particle size and number? Because this debate's been going on for the past 9 years since I've been here, where the ACC and AHA do not make a recommendation on using particle size and number.
Well, that's a great question. There were two, up until about a year and a half ago, there were two major labs in the United States that did the fractionations. One was Liposcience, who makes it in the Carolinas. The other was Mayo Clinic in Rochester, Minnesota. For the past 5 years, every time they would come and we would speak with Liposcience, we said, show us data that fractionating the LDL, the HDL, et cetera, predicts benefit or predicts risk. Or that if we treat it and we change their milieu, we make them better. Every time they would come, they would show us different data. One time it would be this fraction, the next time that fraction. And it became very clear that while it makes great sense, small dense LDLs are much worse and big fluffy HDLs are much better, whatever. It made great sense there is no data. So we actually quit doing them. We don't do them anymore at all. They're sold like crazy by the reference labs around the country because everybody likes to work on their numbers and make their numbers look better. But there's absolutely no data that shows it benefits. And you're right, they really should have come out in the guidelines and said that there is no data. They didn't actually mention it, and they should have.
Well, thank you very much for filling in. Dr. Block, anybody with any final comments? Well, thank you. We'll go for a break, and we'll get back together. Thank you all very much.